Session, and due to our technical difficulties, certainly we're challenged to hear or see or understand anything that we were trying to impart from our Spring Harbor Hospital boardroom. I just want to mention that these changes have been on a very rapid cycle. We have not been able to have input from the large masses that we would like to on certain things, but we have involved psychiatric leadership in the development of templates and the development of this program to help us be ready for January 1st. I'd like to ask at this point, some of you may be listening who are not on the mandatory list of psychiatrists, nurse practitioners, or PAs, and you'd like to just hear and see this presentation in order to better understand what your facilities will be doing. For those people who are voluntarily listening to this, I would appreciate if you could hold any questions and email them to me. We will be developing FAQAs in the future, and hopefully we'll be able to get your questions answered. We really need to spend today with the physicians, nurse practitioners, and PAs who have questions, since this more directly affects them. As I mentioned earlier, Monday's session was certainly not stellar because of our technology problems. We plan to repeat the session, hopefully without problems, on Monday, December 17th. The time will be the same, 4:30 to 6:30, and there will be a communication going out about that. Also want to mention that to support our providers who will be making these changes January 1st, MMHP also will be having our clinical consultant do some on-site reviews sometime between the week of January 7th and 17th, I believe the dates are. We'll firm those up, at which time she will be able to look at notes that you all have done that first week and hopefully provide you with a level of comfort and feedback as to what your documentation is doing for the CPT codes that we now will need to use. As I mentioned, we'll be developing FAQs, and those will be coming out as we get them answered. I also want to mention that today is you are able to receive CMEs for this session. Those of you who are doing this by personal registration at your PC you should have an attachment with a CME evaluation, and that personal registration will indicate that you participated. So if you could send the CME evaluation to me, we will issue certificates from that point. For those of you who are in group sessions, please be sure to, number one, sign in on the sign-in sheet that you should have at your facility. Number two, complete the CME evaluation and return that to me so that I can forward a certificate to you. Now I'd like to introduce our consultant, Lori Desjardins, who is with us from Baker, Newman & Noyes. She is the Senior Manager for Healthcare Consulting.
I don't know if they're all hearing this. Okay, so hi, my name's Lori Desjardins. I am a self-professed coding geek, so
We'll talk about those diagnoses later, but right now I'm looking at a chat window right now that says some of you cannot hear us. So if you cannot hear, well, if you can't, this is interesting. If you can't hear us, send us a message. I'm just going to put a yes out there and send to all and see if we have issues. So this is going to be interesting since I'm presenting and also looks like I'm hosting questions. So bear with the speaker. I feel like a little bit like the Wizard of Oz. Ignore the woman behind the curtain, okay? We're going to talk today about the psychiatric code changes. I can tell you this is a monumental session for me because I started my coding career at Blue Cross, and I went to my first AMA coding symposium when the code set that's being deleted come January 1st was actually introduced in 1998. So that's how old this coding geek happens to be. Having said that, this is a paradigm shift. What you're going to be asked to do is going to be very different from a documentation perspective than what you are doing right now. So I thought the quote from All About Eve might be appropriate. Fasten your seatbelts. It is going to be a bumpy night. Having said that, a little bit on the disclaimer portion. I understand that audio programs are never easy to listen to, and I appreciate the 5 practitioners who are sitting with me at Spring Harbor today. You are going to be my keystone as to whether or not this stuff's flying. But, you know, I find this information riveting. You may not. You can take a nap if you want, but drooling will not be tolerated. All right, so what is going to change? What's changing is basically every code set that you currently use. Interactive complexity or interactive therapy is being deleted. We're going to have to know key components of evaluation and management service. Therapy and how you document that time is changing. Medication management is changing. So all those services are basically going away, and we're going to have to learn how to proceed from here. So here's a brief synopsis of the changes. 90862, as I've already mentioned, has been deleted. For those of you who have any interest in the CPT code set, you will see that there is a new code out there for medication management. It is 90863. Please ignore it. That service is only to be used by psychologists who have the ability to prescribe. And in the state of Maine, psychologists do not have the ability to prescribe. So that code is a we'll blow it off, we'll ignore it. In order to report evaluation and management services related to medication management, you will be using the same code sets that your brethren in the other specialties are using, and those are evaluation and management services, the 99201 through 99215, and the inpatient codes, which would be 99221 through 99233. I did tell you I was a coding geek, so those off the top of my head should not be a surprise. Psychotherapy codes have been renumbered and reconfigured. So gone are, come January 1st, gone are 90804, 90805, and those in that range, and the same on the interactive therapy and on the inpatient side. All of those codes have been deleted. We now are going to report the medical component of any service or psychotherapy that you provide is going to be reported with an evaluation and management code, that code set that I've just described. The psychotherapy codes, we now are going to have 3 codes, and they are time-based codes. They are 30-minute, 45-minute, and 60-minute visits. All right? And what's interesting in these codes is it's 16 to 37 minutes, 38, and I've got those times on future slides. So it's if you provide psychotherapy for at least 16 minutes, you can bill that with one of these new codes. Crisis psychotherapy codes have been added. They won't be reimbursed, but they have been added, so it's always nice to know that you have a way to report them. And then the interactive play therapy codes have been totally deleted, and we have now an add-on code for interactive therapy reported. Pauline was telling me anecdotally that right now Maine Mental Health Partners are not billing for interactive therapy, so it's a non-issue for you. we will have the option going forward as education is provided to report those services. All right, so again, briefly, because I really want this session to talk about real coding examples, and that's why some of the handouts you have will provide that. The 90862 has been deleted. I'm on slide 5 right now. The new code is the replacement codes are going to be outpatient. We have new codes that are 99201 through 99205, and established patient codes, which are 99212 through 99215. Inpatient side, you see the codes there, 99221 through 99223 for the initial service, and subsequent are 99231 through 99233. And we'll talk about what the documentation requirements are related to those as we move forward. Yes, sir.
Can I ask a question about, this is med management, so the first, I'm trying to distinguish this from the initial would be a psych eval in the hospital per se. The next day, it would be a med management note. And I don't understand what the difference between initial and subsequent is.
Initial in the, from an evaluation and management perspective would be the admission codes. So those are medical admission codes.
Oh, okay.
Okay. So if somebody already does, so for example, are you working at McGeechee or P6? Or are you here at
no,
Spring Harbor?
I still work a bit here.
Okay. So at Spring Harbor,
yes.
If you're the one who's doing the admission note, what was the 90801,
Yes.
okay, you're still going to bill that service. The subsequent, the follow-up visit on the second day is going to be coded with a 99231 through 99233. You're not going to code an initial medical note.
Oh, okay. So these initial bits, so we can maybe.
Well, we'll talk about that.
For some of the other folks here, but it sounds like that's a different.
We'll talk about that in a minute, actually, because I'm getting to the initial codes right now. Okay. So moving on, the 90801, that code's been deleted. All right. Anything that you feel familiar with, we'll talk about your own psychosocial issues or psychotherapy issues with relating to getting rid of some of your comfort with some of these codes. The 90801 has been deleted. It is replaced with two different codes. We have a 90791, which is the psychiatric diagnostic evaluation with no medical management component. So my expectation would be that those would be done by LCSWs, those practitioners who are not able to do a medical evaluation.
We are on slide 6 for those who are trying to...
who are listening in but not looking at the slides.
Right. Thank you.
And I'll try and remember. 90792 is the psychiatric diagnostic evaluation with medical services. So for those of practitioners listening, my NPs, PAs, and physicians, you're going to use a 90792 when you do it to replace the 90801. It does not require any documentation changes. So the way you document a 90801 right now will be the way you document a 90792. Okay? It's just a code change with regards to that. Yes. Another question from the room.
I read another packet of information that I thought only physicians could code the 90792.
And physicians in this case mean any practitioner who can prescribe. NPs and PAs are included. So the question was, one of the articles that was read said that only physicians could do a 90792, and from a coding perspective, physicians from a coding perspective are considered those practitioners who can prescribe or bill for an evaluation and management service. Okay. Just checking on any questions out in the field. Moving on to 90802, and again, Pauline has anecdotally told me that you folks are not currently billing for interactive complexity. Those services had not been billed previously by Maine Mental Health Partners. So in the future, if you have a nonverbal patient, if you have a child who requires interactive therapy, you would be billing the initial code without med management with 90791 and the add-on code for interactive complexity of 90785. For the med management with interactive complexity, that's going to be 90792, and again, that add-on code of 90785. We have a slide coming up that describes what's included in the interactive therapy. I won't spend a lot of time on it because, again, that isn't something that's currently being performed. I'm moving on now to slide 7, for those of you trying to keep up with me. We have 2 sets of psychotherapy codes. We have the psychotherapy codes that are standalone. They do not include medical management. And those code sets go 90832, which is psychotherapy, and that should say without E&M, and that's 30 minutes. So if you want to correct your slide, if you're looking at slide 7, it's psychotherapy, cross out with E&M. It's just psychotherapy, 30 minutes. The time component that has to be documented in order to support this service is between 16 minutes to 37 minutes. The 90834 is psychotherapy, again, cross out with E&M, and that's a 45-minute code, and the time range for that code is 38 minutes to 52 minutes. And the last code in this set without the medical management is 90837. That's psychotherapy, again, cross out the E&M. It's 60 minutes, it's 53 minutes or more. And Dr. Ray, it looks like you had a question.
Nope.
Okay, good. All right, moving on to slide 8. These are the add-on codes for psychotherapy. What that means is, in order to bill these codes, you actually have to also be billing for an evaluation and management service. So, in order to use 90833, 90836, or 90839, you must also bill for an evaluation and management service, and those are the 99 codes that I described earlier. These codes are used regardless of site of service, as with the codes within this can be used either in the inpatient setting or outpatient setting. So there's no delineation any longer between in or outpatient psychotherapy services. Okay? The 90833 is our 30-minute code. This should say with evaluation and management service. This is where I got my code, my information wrong, and I apologize. These should actually say with evaluation and management, the 30-minute code. We also have the 45-minute code and the 60-minute code, and again, these code ranges, the time ranges is listed here. Okay, moving on to slide 9. This is a slide that describes, this is the code that describes interactive complexity. And as I said, what I've been advised that this service is not currently being coded, so the interactive psychotherapy codes for nonverbal patients, for example, had not been used in the past. If you are going to use them, here are some of the criterion. I'm going to caution you because when I actually listened to this presentation by a psychiatrist from the APA at the AMA Coding Symposium, and CMS got up and was quite clear that they did not think that the use of translators or interpreters would qualify for interactive complexity. And that has nothing to do with the additional time, but it has everything to do with the fact that the U.S. law on Americans with disabilities do not allow you to bill for additional services for a disabled patient. So that's the reason that the CMS may have issue with the use of translators or interpreters. So I'm going to caution you on that. Right now, it hasn't gotten down to all of the carriers out there. We don't know how the private insurers are going to handle that, but that's the information I have. So you might just want to put a little asterisk in there and put ADA so that you'll understand that those are the complexities related to that. Going on to slide 10. So what does it mean that you have to do an evaluation and management service now if you're also providing psychotherapy or if you're doing only med management? And these codes have been around since, the mid-'80s. All of your brethren in the other specialties, with perhaps the exclusion of radiology and anesthesia, have had to use these ad nauseum. But they are complicated. They are, let's just say they are not the most fun codes to try and understand and get your minds around clinically. So we're going to give you, in the remainder of the program, examples of what we mean from a documentation perspective related to evaluation and management service. I would imagine that you all have had to do these during your residency program. You're familiar with the SOAP format, so going forward, hopefully this will start to make sense. Slide 11. Slide 11 talks about the evaluation and management service with psychotherapy. So what does this mean? One of the key things from a coding perspective, whenever CPT puts a phrase that it has to be separate and distinct from the therapy service being performed, that's code word for saying we need to have the evaluation and management cannot be mixed in with your psychotherapy service. We really need, in the same document, two notes, med management and then psychotherapy. And so one of the things that we provided to you in your handouts is a template that helps you do that. And then we're going to walk through what this means from a coding perspective if you have to pick your level of evaluation and management service. So, for example, when you were doing a 90862, as long as you had some brief element of history, you did some you didn't have to do, but if an exam was appropriate, you did an exam, and then you made whatever adjustments you had to, that was great. That's all we needed from a coding perspective, 90862 all day long. If we're talking evaluation and management services, we're much more prescriptive of what has to be documented. All right? So the level for a SOAP, or the evaluation and management component, is determined by history, exam, and medical decision making. I'm going to try and do this by code level and keep so I'm going to talk in levels of 99213, 99214. In the inpatient setting, I'll try and talk about 99232 and 99233 so that you get, I'll take the coding gobbledygook out of it. We'll just talk about levels that you're going to assign. That's my goal. Whether or not I'm able to do that, you'll be the judge. Therapy documentation, at minimum, needs to document time spent in therapy, and I'm going to stress this. Time spent in therapy does not include the time you spend in med management. So how you document your therapy time is going to have to be quite clear. Progress towards goals has to be documented. The type of therapy provided has to be documented, as well as goals and plan moving forward. All right? So those four things must be in your therapy note in order to support billing for a therapy service. Having said that, that's slide 11. Moving on, we're going to talk about the minutia of evaluation and management coding. And you, of all folks, realize that this is not why you went into medicine. All right? But welcome to the wonderful world of coding. The evaluation and management services are basically broken down into three key components. All right? We're going to talk about these three key components only. We're not going to talk about time documentation, because we're not clear at this point whether or not, if you're providing med management, if you can code based on time. All right, so we're just going to talk based on history, exam, medical decision making. And how does that equate to the SOAP note? All right, so literally, subjective equates to your history. The history from a coding perspective is broken down into three parts. The objective equates to exam. You all know that. That's the easy peasy part. And then we get to the assessment and plan and the overall medical decision making. Medical decision making is broken down into three parts. We have the diagnosis and management options, which most equally or easily equates to your assessment on your patients. We have the risk, which, for lack of a better place to park it, most easily equates to your plan for the patient. And then you have all the data that you do on a daily basis that you may not be giving yourself credit for. All right, I'm going to rush through the rest of this very quickly, because the rest of this handout is truly for your reference. Sometime that you're on call and you have nothing else to do and you'd like to take a cat nap, pull this out, read it, guaranteed to put you to sleep. Okay? It is reference only. What we've tried to do in the templates that we've provided, the examples that we've given you in the medical decision-making sheet, is make this intuitive in some way. The more you use it, the easier it's going to be. Having said that, I made a comment at Monday's presentation that Dr. Garnett wanted me to bring out earlier in this presentation. In the outpatient setting, okay, we are talking about, for the most part, in the outpatient setting, psychiatry is going to be using mostly level 3s and level 4s. When I looked at your notes, okay, so I'm talking 99213, 99214. When I looked at the 20 or so notes that were provided to me for reference, a vast majority of those patients had an acuity that supported a level 4. They had multiple diagnoses that you were managing. There were chronic access 3 diagnoses that were affecting the treatment of your access 1 problems, and all of those combined supported a level 4. Now, the difference in reimbursement from a 90862 to a 99214, this isn't about reimbursement, but I'm trying to give you some concept here. The 99214 is almost double the reimbursement of a 90862. You folks have been doing this all along, but by billing them as 90862s, you've been basically doing yourselves a disservice. Okay? So that's basically what I'm talking about.
What do you mean by levels? I'm sorry.
Okay, so levels of service are your E&M codes, 99212 to 99215. Not in the inpatient setting, rounding or subsequent care would be 99231 through 99233. Those are levels.
Break out the levels.
That's what I'm going to talk about. Okay, so what I'm going to talk about is based on your SOAP note, what needs to be documented to support a level 3 versus a level 2.
Okay. Saying an outpatient, we're finding most of them will be level 3 and 4.
Right.
What's hard to get my head around, as I've written, a progress note, 11 years here, or 12, is under subjective review of systems was always hard for us to get our head around, and then how we would ever put past family social history in a daily progress note. That to me just seems very difficult for our...
And redundant. So the question is, in the inpatient setting, what I'm hearing, what Dr. Ray mentioned is he finds it hard sometimes to document a review of systems, and what's for lack of a better word, it's a little ludicrous to have to reiterate the patient's past family social history. In a progress note. And here's the good news. In a progress note, in the hospital setting, and only in the inpatient setting, you do not need to reiterate past family social history. Okay? So that's the good news. For those folks who are in the inpatient setting, when you are rounding, you do not have to reiterate that the patient's mother is dead. Okay? That's the rule in all inpatient settings, not just in psychiatry. In the inpatient setting, that information's been done in the admission note. It does not need to be reiterated. What I do find when I look at your inpatient rounding notes is that you folks are bringing in medications. Guess what? That counts as a past medical history. So you're doing it anyway. Okay? So we'll talk about that. We'll talk about review of systems. That's why I've got 4 examples that we're going to go through. These are real-life examples that I put in the template to show you code level. Okay? So 3 components on this visit, basically. You have to do a history and whatever is pertinent in an examination to determine your assessment and plan. The most important piece of this, from a care perspective, let's say facts, is your assessment and plan. The rest needs to be documented, or you need to know in order to support that assessment and plan. Now, from a coding perspective, if we're not talking new patient, if we're not talking admissions, if we're just talking subsequent hospital care and subsequent or established outpatient care, you only need 2 of these 3 elements. So you either need history or exam and medical decision-making to support your level, okay? So from a medical decision-making or medical necessity perspective, to support medical necessity, we say that your medical decision-making has to support the level of code. So here's an example. In the inpatient setting, and then I'm going to transfer this over to the outpatient setting. In the inpatient setting, a 99232 requires medical decision-making that would have a patient with 3 or more diagnoses that you're managing would be a level 2. Okay? Most of the patients in your inpatient setting have at least 3 diagnoses that you're managing. The other thing, and we'll get to that, I mean, that's just, this is the easy, okay? So think about how many diagnoses you're managing. So the patient's coming in with bipolar disorder that is poorly controlled, they've got depression and PTSD. That's a level 3 rounding, okay, from a medical decision-making perspective. On the outpatient setting, the same holds true, but this would be a level 4 in the outpatient setting. A patient with bipolar disorder that may be stable, with PTSD and depression, even if they're all stable, that equates to a level 4 from a 99214 from an outpatient medical decision-making perspective. Okay? In the outpatient setting, we have 5 levels. In the inpatient setting, we only have 3. All right. Having said that, we've got the history component. I'm going to talk about that. We've got, that's the coding terminology. This is all part of your subjective note. History of present illness, review of systems, past family social history. History of present illness have 8 components. I've equated those to the code levels as far as the documentation perspective is concerned. So when I talk about level 4 services, I'm going to continually talk, if I'm talking in the outpatient setting, of documenting 4 elements of history of present illness. How has the patient been feeling since their last visit? Have they been compliant with their medications? Do they show any sign or symptom of the medication that you're giving them? So they deny nausea and vomiting. That would be an associated sign or symptom. Is their diagnosis or chief complaint worse or better at a different time? Those types of things documented. What I just described are 4 elements of a history of present illness.
We are on slide 16, incidentally.
Thank you, Pauline. I keep forgetting.
I'll try to pipe in.
Okay, please. So in the inpatient setting, for a level 3 rounding, excuse me, a level 2 rounding in the inpatient setting, you only need to document 1 element of history of present illness. Okay? So a 99232, if you take a look at this, only requires 1 to 3 elements of a history of present illness. Patient is feeling better. I get people nodding their heads back and forth. It's interesting, the dynamics here. Okay, so what I've given you are examples of the elements of history of present illness. I'm sliding through. I just went through 17, 18. I'm now on slide 19 where we talk about past family social history. Medications, which at least I see on every note that I've looked at, would give you all that you need for either a highest level inpatient rounding, or, well, even inpatient, we've decided that you don't need any of those. But in the outpatient setting, 1 would get, is all that we need for a level 4 history. All right? Moving on to slide 20. Slide 20, there are 14 systems in the review of systems from a coding perspective. We have put all 14 in your template. Okay? Your template also has the coding information as well. Moving on to slide 21, this is an example of how we put this together. So this is the logistics of trying to determine whether or not you meet the criteria. So if you'll notice, the line that has 99203, 99221, 99233, and the 99214, that's the level 4 I've been talking about. That requires, under history of present illness, it requires 4 elements of history of present illness. Patient's been compliant with meds. They've been feeling better since their last visit. They have no nausea and vomiting related to the new medication that they were put on. And they find that they've got increased lethargy in the afternoon. That would be a timing issue, okay, as the drug wears off or whatever that issue is. So there's my 4 elements of history of present illness. With regards to review of systems, I need 2 review of systems. What, Dr. Ray, that you normally document in your history of present illness would be the patient denies homicidal ideation. That's actually a review of systems related to psychiatry. Patient complains of being depressed is another. So what else do we need? That's 1 element of review of systems that you always do. Are you asking the patient how they're sleeping? That's a constitutional review of systems. Have they gained weight or lost weight? That's another constitutional review of systems. If you're checking to see if they're having adverse effects from the medication, you will be asking about whether or not they've got any abdominal discomfort, whether there's nausea, vomiting, diarrhea, all of those fun things, whether or not there's respiratory distress, anything that's pertinent, okay, but we only need 2 when we're talking that level, 99214. For those of you in the inpatient setting, that 99232, we only need 1. Okay, So psychiatry can be one of those. So they deny increased suicidal ideation. All right. The last element, which we already talked about, is the past family social history, and that's your medications. It would be substance abuse as well. Either one of those, or if you document both of those, that counts as two. Okay? Moving on to slide 22. Slide 22 is a psychiatric examination. Okay? There are 3 elements with multiple bullets. Each line is a bullet, just so you know, because we talk about bullets in this. So constitutional has 2 bullets, vital signs and general appearance. Vital signs have to be 3 in order to give you credit for that. Under musculoskeletal, you'll notice that doesn't have a box around it. In order, and this only matters when we're talking about a comprehensive exam. In order to get credit for doing a comprehensive exam, and those would be your new patient level 5s, your admission level 3s, and your established patient level 5s, you would need to document both the vital signs and general appearance. Under musculoskeletal, you have to document one or the other. Strength and tone or gait and station. One or the other, but not both, need to be documented. But under the psychiatric portion, every single line there has to be documented in order to support a comprehensive exam. Yes, Dr. Ray?
I'm losing context on this. I thought for initial psychiatric evaluation, the coding changed, but the documentation stayed the same.
Okay, we're talking about 2 different code sets. Okay, we're talking about the Diagnostic Evaluation Service, which is your 90801, soon to be 90792, which you may be using quite frequently. What may happen at Maine Med is because the patient is already evaluated by an LCSW who does that initial diagnostic service, that physician may have to do a medical admission rather than a psychiatric admission note. That's the distinction I'm trying to make.
Okay, but I've done initial psychiatric assessments at CCC and at Spring Harbor. We just do psychiatry. We don't get vital signs on our initial. They're purely the psychiatric.
But if you're doing it right, if you're doing a medical psychiatric admission.
And I don't think anyone here has ever done that. I mean, here at the hospital.
Not at Spring Harbor, because you're the first people to do the diagnostic. At McGeechee, it may be different.
Okay. And at CCC, it may be different.
And it may be different at CCC, and it may be different down at Southern Maine.
So this will be something this will be something that we'll probably use going forward, maybe?
If somebody else has already done the psychiatric diagnostic evaluation, then you're only able to code with an admission code, which would be the 9921221s through 99223s. That's what I'm talking about. So that's the major paradigm shift for admissions for you folks.
In
In the hospital.
For an outpatient setting, where they may have the non-medical evaluation occur by an LCSW, then they'll meet with someone in psychiatry who will then code the old 90801.
That's what she's saying. You can't do both.
You can't do both.
We're waiting, but I don't think an insurance company is going to allow a 90791 for the LCSW, and then for you to follow up with a 90792. That's the idea. Is you create one care plan for that patient. So we need to wait to see what the insurers are going to do with that, but my sense, having worked for the dark side for Blue Cross back in the day, that they're not going to allow you to build 2 diagnostic evaluations. So my expectation is that they're going to allow one, probably from the LCSW, and then you're going to have to code either a new patient assessment with the evaluation and management service.
I mean, it will be clarified because all the doctors here, we do the same initial. So and it'll be very simple.
Right. And once it's clarified, you're going to have to change how you do your examination potentially.
A couple things here and there, but we all do the same initial psychiatric assessment here at the hospital.
Right. And Dr. Garnett was concerned about that because he thinks that you should be able to bill 2 as well. I just don't see it happening from a payer perspective. it is about the money. Although, when they see that one pays less than the other, who knows?
Well, the question is, too, are they paying now with an LCSW as a 90801?
They are not paying.
They are not.
They are not paying for two.
No.
So the question was, are payers paying for two 90801s, one by an LCSW and one by psychiatry? And the answer is no. Patients are allowed under. It has nothing to do about patient care. It has to do about reimbursement. Okay. All right, so there's the physical exam guidance. This is an E&M perspective. This is not psychiatry. This is not the initial diagnostic exam under the psychiatric codes. Medical decision making. Again, I'm going to go through this briefly because hopefully I've got a handout for you that will make more sense and give you some guidance as you're trying to select your codes. But I do want to talk about medical necessity. How am I doing for time? Good. Okay. So having said that, I'm on slide 24 now that I remember to say something. Medical necessity, back in the day when we first started educating physicians on evaluation and management services, we used to say that, you know, if you document, a patient came in for sub-toe, for example, if you documented a comprehensive history and a comprehensive exam, you could get the highest level code regardless of your medical decision making. And when I'm going to use a bad reference, but I do it when I talk to the medical population, so I'll use it with psychiatry. It was very Pavlovian on the CMS's part. They wanted, well, the one area when you look at documentation that was always the weakest before we started was the documentation of history and exam. You've always done a relatively good job of documenting your assessment and plan because really that's what you need to guide the patients. So when this first came out, they really focused on documentation of history and exam. Well, with the advent of electronic health records and high-paid quality consultants like myself out there telling you how to document your history and exam, I jest, of course, they really are putting the focus back where it needs to be, and that's the medical necessity of the visit. And where's the best place to support the medical necessity? That is in your assessment and plan. So what I'm here to tell you is in your subsequent hospital care codes, so your rounding codes in the hospital, and your established patient visits in the outpatient setting, your medical decision making is going to have to support the level that you're billing. So if you want to bill for a level 4 service, your medical decision making has to be one of those elements to support that level 4. You can then either have a detailed examination, a level 4 exam, or a level 4 history, but medical decision making has to be one of them. So if I was going to reverse that, if you documented a level 4 history and a level 4 exam, but this patient has one stable problem such as ADHD that's well controlled on meds, and there's nothing else that's documented in your assessment and plan related to any other comorbidities or problems that the patient has, that should be coded as a level 2 because that medical decision making only supports a level 2. All right, so I put it on its head. Moving on, and I'll show you examples of that. I talk about what the lengths are, and this slide 25 explains what I just tried to verbalize. You know, slide 26, what we're talking about. So here's my goal for today, and only you can judge whether or not I'm successful with this. What I'm going to try and do is make the medical decision-making portion of this intuitive, because this is the most convoluted part. So I'm going to talk about number of diagnoses and put them into categories. I'm going to pigeonhole this, so to speak, so that you can get a better feel of what we're talking about. So moving on to slide 28. What affects the acuity from a medical decision-making and coding perspective? It's the number of problems that are being assessed. Are those problems new to you as a practitioner? So one of the things we talked about on Monday is, for example, here at Spring Harbor, if a patient's admitted over the weekend and you then are picking up the care of that patient on Monday, those problems that you are addressing on Monday are new to you. So the complexity of your medical decision-making is going to be higher on Monday than it will be on Tuesday once you've assessed that patient. So the patient's status doesn't change. It's still a rounding code, but the complexity of your medical decision-making, if you document that this is the first time you're seeing the patient, adds to the acuity. Okay? If the problems are established, are they stable? Are they worsening or are they unstable? That supports higher acuity. What are the risks to the problems related to the patient? And how much data are you reviewing? And this is where all physicians fall short in your documentation. There's not one of you that if you have the patient's record in front of you the first time you're going to see him, you are looking at that. You are reviewing that patient's record. How many of you actually document that you reviewed the chart? Very few of you, my experience tells me, actually document that. That adds to the complexity of your medical decision making. Guess what? You meet with family members all the time. It's so easy to decipher who's lying about what, right? The example I have is my mother would go to the pulmonologist. She would sit there right in front of him and tell him that she was taking her meds as prescribed. I would be sitting in the guest chair, not shaking my head no. Have I just added to the complexity of that physician's medical decision making? Tell me that doesn't happen in psychiatry. Okay? Document that you're getting additional information or controverting information from the patient, which you folks do pretty well, adds to the complexity of your medical decision making. Okay? Yes?
We had a code here, and I'm not sure this is the right time, but it's the family meeting. We just do family meetings a lot here, and it was an O. And that meeting could range from a half hour to an hour and a half to, I've been in 2-hour family meetings here.
Mm-hmm.
And there was no, my note reflected some of that, but there was no pieces or elements that I knew. I built an N. Not right, family meeting N. I just built family meeting code here.
All right.
I didn't see that yet in the packet, but that was.
Family meeting codes haven't changed. So there are family meeting codes, but I'm probably going to argue that those.
It was a descriptive narrative note. It was not organized like this.
Right.
No, you had to have.
Because it's just a therapy note, quote unquote, just a therapy note. There are less documentation criteria.
You could cover anything in that.
Right.
You can cover meds, non-compliance, family dynamics, disposition.
And so we might want to code those as psychotherapy notes rather than family meeting notes. If the patient's present for a portion of them, reimbursement in that may be at a better level. Is the point I'm trying to make.
You're there.
All right, so these guys are pointing to each other. We digress. All right, so the rest of this talks about the audit criteria are, and I'm going to skip this for right now because one of the handouts you should have, and I'm pointing to the speaker as I say that, but for the folks here at Spring Harbor, I have a one sheet that says medical decision making.
And this was part of the handout that was sent.
So the handout, the title of the handout is actually medical decision making, and if actually you bear with me, I'm going to see if I can share that. It's medical, it's MPH. The title was MMPH template 19, oh no, that's the wrong one. I apologize. Let me. See, this is where the Wizard of Oz thing comes in. There it is.
Right there, medical decision making.
It's medical decision making doc. And now I have to share that screen with you folks. Where?
Medical decision making doc M, is that what you're talking about?
Right there. Okay, so hopefully all of you can see this now on your screen. So what I've done, and this matches the template we're now going to go over, is this breaks out data, assessment, and how those equate to level. And then if we slide down here, we then do the plan piece. And then what I try and do is put all of these together so that you can determine what your level of medical decision making. So isn't this convoluted formula fun? All right, so here's where I'm going to try and make this a little more intuitive so that you don't have to count on your fingers and toes to get there. All right. I'm going to talk about, let's do this. I'm going to, so you can put the slides away for now. We're done with those. What I'm now going to do is, if you would bring out the form that looks like the MMHP template 2013. Okay, this is the generalized template that They're all over here. This is a generalized template that was created with the assistance of the staff,
our medical directors.
Thank you, at MMHP. All right, so this is a combination of additional information, but it's basically formatted on APA forms they've come out with. And this is for evaluation and management services. So it starts off with the chief complaint. So everybody should be looking at a blank one right now. So it has a chief complaint. Why are you seeing this patient? We then go on to the history of present illness. That's your free text. Some of you are in an electronic health record. You know, you have templates that you're using. Hopefully they will look similar to this. What I've tried to do, and you can't really see it too well, although let's just see if I can zoom this just a tad. All right, so we've got the entire window at least. So what we're looking at is history of present illness. You'll notice right here what I'm highlighting. That actually has the code levels. So how many of what do you need in order to support a level? Okay, so if you take a look over here, it has established a 99212 or a 99213 requires 1. And I apologize, some of the handouts that you have should be more updated. We weren't able to download all of these for the presentation, so the new one actually has a 99212, a 99213, a 99231, or a 99232. What I'm showing you right now is an outdated version on the screen. The ones you have in your hand should be correct. All right, so there's the coding from that perspective. So after you've done documenting, here are the elements related to location, quality, severity, duration. We're trying to give you all of the information that's needed from a coding perspective so that you can take a look at what you've documented and quickly say, oh yeah, that meets a level 4 or a level 2 rounding or a level 3 rounding or whatever the issue is. We then move on to past family social history. Notice medications are listed. You would list them here. If there are any social or family histories that you want to put in here, you would do that. If the patient has substance abuse issues, you would circle yes, and then document what those might be. Excuse me just a moment.
It looks like there's, I always thought the whole note was graded in terms of complexity, but it looks like every component of the SOAP is graded.
It is. From a coding perspective,
From a coding perspective, and that's something I wasn't aware of.
I'm going to interject that I'd like the people who are here to kind of hold their questions so that Lori can get through this, and then we can take questions both from here and the people who are accessing us remotely. So if you've got more questions, just jot them down so we can deal with them at the end of the presentation.
Okay. Which means this is about to get really boring just listening to me, just so you know. All right, so past family social history. Again, elements related to that. If you document review of systems or past family social history in the HPI, it counts in those categories, but you just need to know that there are different elements that have to be there to be supported. Under review of systems, so we would look at review of systems, obviously psychiatry we put as number 1, go figure. You folks probably are going to document that. And then we have all of the other elements. If it's negative, just put a check. If it's positive, you have to make a comment. All right, so that's the criterion. If you indicate that something is positive, so the patient says that they're having blurry vision, you would check off positive or make comment. Patient says that they're suffering from blurry vision ever since whatever med was increased. All right, that's a review of systems. And then we put all of those together. The 3 components of your medical decision making are actually put together in this portion of the template. So you can actually say, okay, I got 4 elements of history of present illness, 2 review of systems, and I reviewed the patient's medications. That means this visit's a level 4 from a history perspective. Again, we're trying to make this as simplistic as possible so that you don't have to count on your fingers and toes. You have a place to do that in this template. Under the specialty examination for psychiatric care, here are all the bullets. When we say bullet, that's that little dot that we're talking about. Okay, so all of these sliding through, you can see when we get to the speech, thought process, all of those are a part of the psychiatric elements of this examination. Excuse me. Moving on in the test, so we're now towards the bottom, we have medical decision making, and I have data there. Some of the things that count towards data management on these patients that you may not have thought about is if you review the chart, and that's usually done in the history of present illness, but you need to indicate from review of nurse's notes. That's more complicated than getting the history personally from the patient. That adds to the complexity of your medical decision making. Outside records reviewed, so if you have to request something from the patient's counselor, you get that, that's additional documentation. Additional history from someone other than the patient. And in that case, I mean family member, non-clinician. So you might want to put note there because we weren't exactly clear on that. So this would be a non-clinical. Decision to obtain old records. The things that have higher acuity as far as point value is personal review of the chart and obtaining history from someone other than the patient, so family members. Okay? Labs, if, for example, if the patient's had an MRI that you review, if they've had laboratory services, that adds to complexity of the data review. So in the inpatient setting, here's what I'm thinking. There are probably, at least when you're picking up the initial care of this patient from someone else, you're going to be looking at labs, you're going to be reviewing that patient's chart, and you may be getting lab patient chart, and you may be discussing the care with a person, someone other than another practitioner. So you may pick up you may get a report verbally from the physician who is transferring care that day. If that's the case, you've got the highest acuity from a data review perspective that you can have, which means that you might be looking, at least in that initial, at the level 3. Okay? Because the level 3 requires high complexity. So from a data perspective, in the inpatient setting, I think you folks do that a lot. And at the very least, on a daily basis, you're doing level 2 data management. Because you're always reviewing the chart, and if there are lab values, you're reviewing those. Okay. Let's go down to the diagnoses, which would be the assessment portion of this. All right? So for an assessment portion of this, what we have over here is the improved worsening stable, okay, the IWS. One of the questions we got from from Monday's presentation is, do you always have to circle that? And the answer is no. It's only if appropriate. All right? But, and it doesn't have to be for all axes either. So you can, and you don't have to document all axes. Is that the right word? Axes? No, it's axes. All right. And I'm talking to myself. You can diagnose that later as well. So you list the diagnoses that you're treating here. If they're not stable, documenting that adds to the higher level complexity in those patients. If they are stable, different story. All right. The last piece of this is the plan, and that's just your free text on what you're going to do with that patient. So here I'm going to try and give you an example. Patient comes in, and again, this is the simplistic version so that you can kind of get the gestalt of this. First time you're seeing a patient with bipolar disorder. It's a new onset problem, right, to you. Patient may have had it for 20 years, but it's a new onset problem to you. You are already starting in the outpatient setting at a level 4 medical decision making if you are diagnosing a patient or seeing a patient for a new problem. Okay? So the assessment piece is level 4. In the inpatient setting, that's a level 2 rounding. Okay? The next piece would be the plan for that patient. If we think about this, and I'm going to flip over here just quickly to, I have to do this manually, I apologize. I'm going to flip over to my medical decision-making sheet that we talked about a little earlier. All right, so what I'm talking about here is the assessment. New problems. Right here, I'm going to highlight, no, I can't highlight, but anyway, right here. What's in black? New problem was enough to create a care plan. This patient has bipolar disorder. There's no other diagnostics that have to be done. If you take a look at the level from a coding perspective that assessment would be, it would be a level 4, 99214 and 99204. In the inpatient setting, from a rounding perspective, that should be a 99232. If you guys want to make that correction, that should be a 2.
99232.
Right. Modern technology, I get to make it appear on your screen. If this patient came into you with a new diagnosis, maybe they've started to have whatever delusional aspect to their personality, whatever's going on, and you need to do further diagnostics to see if there's a biologic component to this, all right? That's when we're talking about a new patient who needs additional workup in order to come up with a definitive diagnosis. And that patient would go to the highest acuity. That would be a 99215, a 99205, or a 99223, and a 99233. Okay, so the question is, do I have enough to create a care plan for this patient? If the answer is yes, then we're looking at those a level 4 or a level 2 in the inpatient setting. Level 4 in the outpatient setting, level 2 in the inpatient setting. If the patient comes into you with a new problem that you cannot create a care plan because you don't know all of the aspects of what's going on with this patient, that patient moves up to a level 5 in the outpatient setting, either a 99215 or a 99205, and in the inpatient setting, it's a level 3, 223 or 233. And you had to write those into your medical decision-making table. All right, more likely, however, is the established problem. So from an established problem perspective, we've got several different criteria. We've got established control problems, all right? So that's why if you take a look, I said if you're dealing with a patient with 3 diagnoses, whether they're stable, if they're stable, that patient's going to be a level 4. On the outpatient setting, a level 2 on the inpatient setting. If they have 4 or more problems, at least from an assessment perspective, that's a level 5. Now, I'm giving you these categories or these levels by category. Just because the assessment is a level 5 doesn't mean the overall medical decision makes it a level 5. We have to have either data and or plan to meet that criterion. Aren't you sorry you haven't been in family practice all these years? This is what they deal with all the time. And we wonder why they're dropping out of medicine. Okay, so that's from an established patient perspective. Unfortunately, or whatever, most of your patients, at least to see psychiatry, probably aren't as stable as you would like. So if we're seeing patients with unstable or poorly controlled diagnoses, the acuity goes up, the fewer diagnoses you need. So if you're seeing a patient with 1 unstable problem, ADHD that is poorly controlled, it's a simplistic one, but I'm going to use it anyway, that would be a 99213, a 99203, or a 99231, depending on the type of patient or location of service. If the patient has 2 or more unstable problems, they move up to the highest acuity from an assessment perspective. So they're back up to the 5s and the 3s. If we have a blend, which is frequently the case, we have a patient who has multiple chronic disease diagnoses, some are stable, some are unstable. If you have a patient with 1 stable problem and 1 unstable problem, that's the level 4 or the level 2.
Does that matter if it's medical and psychiatric?
It can be a combination.
Everything? Okay, uncontrolled diabetes, but I'm not treating that in any way.
But is it affecting the care?
Sure,
Yeah.
yeah.
Yeah. Absolutely. all axes. 1 and 3 count. And of course, the GAF score helps as far as the stability of the patient too. So if you're documenting that, if you put in a GAF score of 20 versus a GAF score of 45, that helps support the stability of the patient. All right, I'm not going to talk about self-limited or minor problems because face facts, you're not treating those in a general sense. All right, so let's move down to the plan piece, and then I'm going to move back up to data. So from a plan perspective, let's concentrate on these two categories. We've got the level 3 categories, or the 99231, so this portion. And take a look at this. What's the one that fits into psychiatry most likely is the stable chronic illness, right? So how many, we could easily put stable depression, stable bipolar, any of those would meet the category of a level 3. If that's the only problem you're addressing, that's level 3 from a plan perspective. If it's not stable, or if you're dealing with multiple, 2 or more stable chronics, that's when we're moving up to the level 4 on the outpatient side and a level 2 on the inpatient side. So that's the patient who has depression, bipolar, and PTSD.
These numbers here are the levels, aren't they?
Yes, they are.
I just realized that.
The levels on the side are the numbers on the side are the levels. That's what I'm trying to do. Thank you.
We have 4 levels.
We have 4 levels of medical decision making.
Did you mention a level 5 at one point?
A level 5, if you take a look, think about your inpatient admissions. Okay, that's these. So, and this is where psychiatry is actually specifically discussed. Psychiatric illness with potential of threat to life, to self or others. Okay, this is your admission. You're not admitting a patient to an inpatient setting any longer. There isn't an insurer, including Medicare, that's going to say it's medically necessary to admit a patient into a behavioral health facility unless there's suicidal or potential or threat to other potential. That's one of those major criterions for inpatient admission. Inability, but that's a threat to self. Okay, so your admissions should all meet this criteria. If the patient continues to have suicidal ideation and they're still at that threat, the risk or plan for that patient is still going to be high. Okay? So here's what may happen. You may have a patient who comes in, and let's just use this as an example. You may have a patient who comes in with 2 stable problems. Okay? So we're treating bipolar and depression. They're both stable. That example?
Bipolar is the effective diagnosis. Depression is inherent in the bipolar.
Yeah, but you can...
Either they're depressed phase or manic phase. But when we say bipolar, when we say depression too, you can't be both bipolar and have a diagnosis of depression. Bipolar captures the affective syndrome.
Okay.
You have to qualify where you are on the spectrum.
Okay, how about psychosis? We have bipolar with psychosis?
You can have bipolar with or without psychosis. You can have bipolar. You can have bipolar.
PTSD and bipolar. That's perfect.
Beautiful.
Okay, so the non-clinician finally got it right. Okay, so we have bipolar and PTSD. And it used to be called manic phase, but it's not. I understand that. All right, so we got bipolar and PTSD that's well controlled, right? That would be a 99213 from an assessment perspective. But from a plan or risk perspective, it's a level 4. You see it? So 2 or more stable chronic illnesses from a plan perspective, from a risk perspective, is a level 4, but it's only a level 3 from an assessment perspective, which means if these are the only 2 things that's documented and we don't have any data review documented, the medical decision making on this patient drops to the lowest level. So in this case, it's going to be a 99213. So this visit for a patient with bipolar and PTSD is going to be a level 3. If they also have diabetes if they have hypertension that is being affected by the medications that this patient is on, so it's affecting the care of your patient, then that patient would move up to having 3 problems, level 4, okay, and level 4 from a plan perspective. So all of those comorbidities, it's important to document if they actually affect the care of that patient that day.
And these codes you've been highlighting are the
outpatient code. All right.
So only if it affects care that day. That goes back to my earlier question about
if it's affecting
a chronic diabetes patient, it's not really bearing on that particular day's work.
But okay, so let me argue that point. Patient has diabetes. The medications you have that patient on are going to potentially affect that diabetes. So I'm going to argue it does affect the care of that patient that day. You're not managing their metformin, but you have to be aware that they're diabetic in the management of the drugs that you're giving them and how that will affect their diabetes. So I would argue that it would. You're not changing meds related to the diabetes, but the fact that they have diabetes is an integral part to the management of that patient's process. Acknowledging. Exactly. Or just the fact that this patient is a type 2 diabetic. So they have bipolar, PTSD, and a type 2 diabetic. That adds that's the complete story in your assessment. And it can't just be in the patient's medical history. You have to, in order to get credit for it, you have to bring it down into your assessment. All right? So the last part of this I want to go through, and then we're going to go through examples quickly. Yes.
So we have questions. Time for questions.
Okay, I'm trying. I'm very trying, Pauline will tell you. So under data, you'll notice that I've got all of these things, and I've got, for example, I've got labs, imaging, tests, and I'm pointing, for those of you who can't see me, I'm pointing to the screen. So under labs, you get 1 point per category. So if you order an EKG, that's a test in the medicine section. If you order an MRI, that's a test in the radiology or imaging section, obviously, and labs are labs. So if you do all 3, it's a total of 3 points. So this patient is having chest pain. You don't know if it's due to the anxiety, if they actually have cardiovascular issues, have an EKG, you get a point for ordering the EKG. If you personally review the image, such as interpret the results of the EKG that were read by cardiology and say, yeah, I don't see ischemia or whatever else is going on, then great, you get extra credit for personally interpreting that image. I don't see that happening so much in psychiatry, but you may. If you decide to discuss with others, and again, the discuss with others is other practitioners. It's 1 point. And then under chart review and additional history from, you get 2 points, period, whether or not you review the chart and have a conversation with the family or just review the chart. It's 2 points. And these points matter because this is the only part of this that I have to have you do math. Okay? If you get 3 points from a data perspective, that's our level 4 on the outpatient side or the level 2s on the inpatient side. If you do 4 points, that's the level 5s on the outpatient side and the level 3s on the inpatient side. Okay? So those are the 3 components of your medical decision making. The easiest way to get the gestalt around this, honestly, because when I looked at your records, you are doing a lot of this. If you are seeing a patient with at least 3 diagnoses, you will if everybody would start with example 1 from your handouts, which I, of course, don't have open yet, and I will do right this minute. So now you should see example 1 on the screen. These are taken from real dictations and real notes that I was given by Pauline. All right, and what I did is I fit them into this template just to give you an idea how they work and how they'd be scored. Okay? So, and I'm going to get these out for myself. Pardon me? It's hard to read from here. You are right. I'm going to blow this up. There we go. All right, so this is a patient who's a 9-year-old with a history of ADHD and parent-child relation problems. Never happens in any of your practices, I'm sure. This is not, common. So what happens with this patient? From the note, at the last visit, the patient was prescribed a medication for insomnia, presents accompanied by his maternal grandmother, older brother, and younger sister. Oh, this must be fun. Reports that he's been getting better sleep since the medication was increased to 100 milligrams at nighttime. School has been going relatively well. Anyway, you can read this. There are 4 elements of history of present illness documented in this note. We have a modifying factor with the medication change. The fact that this patient's been feeling better or getting better sleep since the med has been changed is a timing issue. Doing well in school is a quality. And we have, there's one other issue with context, I believe, agreeable to possible referral. So we have 4 elements of history of present illness. If you underline or circle them, they would be there, and that would give you a 99214 from a history of present illness issue or respect. If you take a look below that under past family social history, we have medications on this patient that were documented. So that would meet level 4 criteria. Again, this is an outpatient patient. All right, so right now, history supports a level 4. Past family social history supports a level 4. If we did not have 2 elements of review of systems, it would not equal a level 4. We have to have 2 review of systems in addition to these other 2 elements to support this history or the subjective portion of this note being a level 4. But what I have in the text box is what was dictated by the physician whose note I used. Continues to display some irritability and frustration at home. So there's our psych review of systems. Becomes angry and anxious. His grandmother reports ongoing symptoms of anxiety. Denies anxiousness. Okay, so there's they're contradicting each other. Under constitutional, this patient denies any problems with insomnia, or the insomnia is being better, and that was actually out of the history of present illness. We didn't count it there, so it counts as a review of systems from a coding perspective. So what you put for review of systems in your HPI will count in this area, just so you know.
Doesn't have to be more specific.
No.
Appetite, sleep.
1 element.
Constitutional is okay.
Yep.
Okay.
Okay, so when I put all these pieces together, this is a level 4 history. Very concise note, typical, I would assume, for what you're doing. Now, under physical exam for this patient, if we take a look, we have general appearance documented, right? And then if you flip over to page 2, the next part that's documented here is thought content is negative, so there's 1 additional bullet for description of abnormal or psychotic thoughts. And then we have description of patient's judgment and insight is documented. And then the last piece that's documented is mood and effect. So if we count up those bullets, we have a level 2 examination. We have less than 6 areas documented, so that's a level 2. And if this were in, do you see that? If you add up at the top here, bullets, at least, no, level 1, sorry, at least 5, right here.
Do you have 5 or how many do you have?
5.
So you have level 1.
Level 1. No, it's a 99212, or in the inpatient setting, a level 1 from a history perspective. Okay? So outpatient, this is a level 2 examination. Next step, the medical decision-making piece. No data documented in this note. And that's fine. You don't have to. If you're not doing it, not a big deal. But here are the diagnoses that were documented. We had attention deficit disorder, parent-child relationship problems, anxiety, and sleep disturbance. We have 4. So from a medical decision-making perspective, what do we know? We're at a level 5, at least from an assessment perspective. The assessment on this patient, he continues with additional information, med changes. If you flip over to page 3, the plan for this patient is continue meds. Going to determine whether or not we can get him into a therapist or her, whatever is appropriate. If we skip down to the last attachment, this is the medical decision-making piece. There was no data done. So notice it's highlighted on the screen. Level 5 was, is the 4 or more chronic illnesses from an assessment perspective that, or established problems that were addressed. But if we go down to the assessment piece is only a level 4. This patient isn't enough acuity to be as high complexity. Okay? So what that means is if we put these things together, we had a level 5 from the number of diagnosis and management options, so that's the assessment piece. We had a level 4 from the risk or plan piece, so this patient's overall medical decision making, because we have to have 2 of the 3, equates to a level 4. So when we put all of these things together, we had history that was a level 4, exam that was a level 2, and medical decision making that was a level 4. We can throw out the lowest one, and this patient is a 99214. So, moral of the story, this is complicated coding. Think about it from this perspective. Did my medical decision-making, what does my medical decision-making equate to? It's a level 4. Do I have either history or exam that meets or exceeds that level 4? If the answer is yes, I code it as a level 4. I'm going to quickly move on. Let's do an inpatient, shall we? Let's do number 2. Colleen's looking at me like she's worried. Time. I know, time. So pull out the example 2, which is an inpatient rounding note.
Another child.
It's another child, I know. I'm sorry. We're all children at heart, aren't we? We can transfer this, you know. All right, so the chief complaint. Here's the problem. You have to have, even in rounding, I'm going to repeat this, even in rounding, you need to describe why you're stopping in to see the patient. Failure to do that means that we can, it may possibly mean that we have to throw the entire visit out because it doesn't meet medical necessity. What I frequently see, at least in the medical notes that I see, not the psychotherapy or psychiatry notes that I see, is patient feels well, wants to go home. That's the first line in the history of present illness in most rounding notes. If you don't tell me why you stopped in to see the patient, there is no medical necessity to support that rounding. So it would be very important to say day 2 of depression, PTSD, and all of those other things. Okay? So follow-up depressive, whatever those, I can recognize it from here, PTSD, whatever. All right, so if you take a look at this note, if you read this, there's documentation from the nurse, what the nurse has told you is going on. There's documentation of the patient. She didn't want to meet with you. Well, good for her. She rates her mood. So how does this all equate? We've got quality, severity, timing, and modifying factors on this patient. It's a level 3 from a history of present illness perspective. We don't need past family social history documented, as I've already told you, for rounding. But in this case, medications are listed. You need it from a clinical perspective, great. We don't need it from a coding perspective. Under review of systems, here's what was documented in this note. Denies anxiety, anger, depression, SI, all of those fun things, right? But only one review of systems was documented here. That drops this level of history down to a 99232. In order to continue to support a level 3, I would have needed 2 review of systems. So the overall history on this patient, if we slide down and look at this, overall history is going to be a 99232. Failure to meet one element drops it to the next requirement. When we're talking about history, it's exacting. If you miss one thing, you drop a level. Under physical exam for this patient, we have level, I can't see it from here, a level 3, because how many bullets get documented? No, I'm missing it. Yep, it is a level 3. We have clean and appropriate, so I've got 1 bullet. Under general appearance, I've got musculoskeletal, 1 bullet. We've got thought process documented. We've got description of abnormal psychotic or psychotic thoughts. We've got orientation, memory, attention, mood and effect. We have 6 or more bullets documented. Do we have 9? Sorry, 1, 2, 3, 4, 6, 7, 8, 9. So that's a level 3 examination on this patient in the rounding. And then under medical decision making, look at all the problems that you're addressing. We've got 3 chronic under Access 1. We've got severe family conflict of educational problems, which is your Access 5. What's going on with this patient from an overall medical decision making, if you want to flip the page and look at the medical decision-making tool, we had a level 3 because they had 4 or more problems that were addressed. From a risk perspective, however, this patient is a level 2 because none of these are at the highest acuity. This patient's at life threat. From a data perspective on this patient, we had the nurse, we had the review of the chart, but overall, because plan is the lowest element here, we're going to go a 99232 on this patient. If there had been lab values, if there had been discussion with the patient's family or another practitioner, this could have moved this up to a rounding level 3 based on the data complexity because the exam supported it as well. Does that give you half an hour for questions, Holly?
I wonder if we should not cover example 3, which has an add-on code.
Yes.
But after that, yes.
All right. So the last one, pull out number 3, if you would. And this is the one that actually has the psychotherapy component to it. And let's hope I have this one on the sharing screen so I don't make you pause anymore. And lo and behold. Okay, example 3 is actually an outpatient service with psychotherapy. And before, when we were talking about this, under the 90805 code, what? Your screen sharing was. Is it good now? And just make sure that everybody's still sharing this one. Looks like we are.
I think it was when it was the most
I'm out
over there. Yeah.
All right. So under the 90805, you would blend the medical management with your psychotherapy services, right? It was a blended note. It's the way you practice medicine. Unfortunately, because we are now reporting with separate evaluation and management codes, you have to document the medication management or the medical management piece in the way that I've just described. And the psychotherapy portion of this note has to be documented in its own portion. Okay? So if we walk through this quickly, we have a level 4 HPI, we have a level 4 past family social history, and we have at least 2 review systems making the history on this patient a level 4. It's in a very abbreviated examination on this patient, so it's a level 2 exam. down to medical decision-making on the bottom of page 2 into page 3. This patient has multiple chronic problems that are being addressed, but they're all relatively stable, giving us, from a medical decision-making perspective, this patient is going to be a level 4. What's important, however, is now the psychotherapy. If you take a look at this therapy note, this physician documented 20 minutes of therapy time. And we have to carve out the therapy time, so this patient may have been scheduled for a 30-minute visit. The physician spent 10 minutes doing the evaluation and management service. We then have to carve out the 20 minutes of psychotherapy time and say, okay, we had a half-hour visit, but 20 of it was spent in psychotherapy and what needs to be documented. We have to have therapy diagnosis as our chief complaint. So you can say it's the above diagnosis, that works. Okay? We then are going to talk about progress since last visit. And this patient was put or taken off a med. It isn't working as well, and now it's causing some problems. All right? So that's our progress since last visit. Therapy intervention provided. We talk about it here. We also took some of the circles or information that was available in the McGeechee templates that they have. So if you're providing supportive therapy, you can circle that. So as long as it's clear that supportive therapy was done, you can briefly say, you know, here are the goals towards treatment. Same thing with patient education. If you're providing any of that, those can be circled here.
Comment or just circle?
As far as education, circle is fine. As far as therapy, we'd want a little more information. Good point, though. We'll add that comment. And then the plan. So we're going to monitor symptoms. We're going to put them back on the meds, and they're going to call you if there's any increase. So there's your 20-minute appointment related to the psychotherapy.
And even if they're in individual therapy, this is okay to be billing therapy on top of, let's just say they had an appointment the same day with their therapist. I've seen that at CCC. Can we do that? I mean, I'm just saying that.
Probably not. So the question is, if the patient's already seeing an LCSW, same day, you're only going to get the E&M service, just like you only get the bill for the 90862 right now. You'll be able to bill for a 99214 in this case.
It's okay if they're doing therapy on another day.
It's okay if they're doing therapy on another day.
Okay.
Having said that, that leaves us 25 minutes for any questions that we may have. This is so different than Monday's presentation, let me tell you. There's a lot here to digest. And quite honestly, if we could make it any more convoluted, I don't know how. Having said that, you know, even the lowly neurologist, and I'm teasing when I say that, has gotten the concepts of E&M coding. So if a neurologist can do it, there's no question in my mind that psychiatry is all over this. Okay? It's just a change in how you document. And it's going to take some time to get used to. So what I think Pauline's discussed is you're going to have somebody who's going to review some of these notes and sit with you. Did you say, how did you describe that person?
Our esteemed consultant.
Okay, so the high-priced, overpriced consultant will be doing that. That would be namely me. So I will be looking at your notes and sitting with you individually so that we can, if you have questions going forward, you can do that. Having said that, we can now open this up to questions. And if you have questions, you can raise your hand. I don't know how to do this. If anybody else can manage this, it would be great. As the high-priced consultant notes coding, not necessarily. Okay, you've got the control. I've just rescinded control. There's an issue in and of itself.
You're not talking those questions, so you're talking.
If somebody has a question and you're on the phone, you can certainly unmute your line and just ask your question. I'd encourage you to do that. For those of you who have the chat capability, you can type in your questions and we'll be happy to answer those. And failing that, I could sing, but I'm sure you don't want that either. So, anybody? We've silenced the folks here at Spring Harbor. So in the interim, while we're waiting for people to chime in, does anybody? Okay.
I work only in outpatient. I've always thought of a 90801 as my initial, and I would do a good therapy code for just the med management code. It's possible to now have a new outpatient code that's not an evaluation. Is that right? Like the 90862, I can now have a new outpatient visit?
If this patient is new to your practice, okay, so the question is, this particular physician works only in the outpatient setting. And so initially, the codes, the standard code set was 90801 and 90862. But if somebody else has already done the 90801, you now have the ability to code or document a established patient visit or a new patient visit, depending on whether or not they're new to the practice, using the evaluation and management services.
New patient indicates a patient who has not been seen at the practice for 3 years prior to that visit.
There are going to be some of those.
Yeah.
Okay.
It will be a new patient to me, so I'm thinking I will still do everything I would do in my old 90801 in that visit, because clinically I would need to for that.
So that's probably going to be a 99215.
A lot of patients do fall into that category.
Right. A
It
99.
will only be an E&M code. It won't be an evaluation code, even though I'm doing an initial evaluation.
If someone else in your practice has done an assessment, a psychiatric assessment on that patient, then you're only going to be able to use the med management, the medical E&M codes.
That's where I was thinking about.
Yeah.
Okay.
So that's the answer. Do we have?
I'm just looking to see if there's any. Okay, here's one. Can you read that?
No. Can somebody read it and then I'll answer? Is that okay?
Are we
Great.
supposed to document E&M coding that we spend greater than 50% of time counseling? That's from John Robinson at 1:08 p.m.
Dr. Robinson, we don't have an answer to that right now. Under normal E&M circumstances, if this were medicine practice, I would say absolutely. The problem I have with saying yes, that you would be able to code the counseling time with that, is we have counseling times that are available in the psych management section. So I don't know. Right now, I'm unable to answer that question and tell you that, yes, you'll be able to use the counseling codes. APA says yes. I'm a little concerned that our private insurers are going to say, sorry, you should be using the psychotherapy codes if you're doing any type of counseling. And we're only going to allow you to use the 3 key components, not time for coding, evaluation, and management services. But that's in contradiction to what the APA says right now.
I would also add that we have not received guidelines from any of the commercials yet on what they are accepting. As those come out, we will be sending out that information to all of you.
Okay, so we have another question on the screen. How do we capture time spent calling other providers, PCP, and therapists?
I'm going to tell you what I tell everybody. That's good medicine. Unfortunately, it's not a reimbursed service. The time spent not face-to-face with the patient is generally not a reimbursed service.
And Sandra Fritsch said, what can we do about outpatient consultations from a coding standpoint?
Right now, Maine Mental Health Partners, Pauline has advised that you are not using consultation codes for any of your payers currently. So those services are going to either be coded as new patient services or established patient services. Am I correct, Pauline?
Correct. We have some issues with some payers that will not pay the traditional consult codes, which were like 99241 through 99245. Hence, we have made a blanket decision not to use those codes because you have other ways of providing that service.
There was one earlier that
Bill, I take up that.
Suzanne's gone, and she's not a clinician, so that would be part of the.
And then there was about taking vital count as data collection. That
No.
was much earlier.
Vital signs is not data collection. Vital signs is an examination point.
Other questions up so far? I'm going to ignore about Dr. Ray and his ADHD medication.
Yeah.
I'm a dietitian. I've been working online. Is there anything that I can do to support helping with the coding? I know you mentioned sprinkled nutrition in there a little bit. I don't know if it's my site or stuff.
That wouldn't go towards the medical management.
It can help with the practitioner.
It helps the patient. How's that?
Yeah, that's true. So that's when I'm working with the dietitian.
Yep. Absolutely.
I might also add to those people doing this remotely, again, if you're having problems with the chat room or you can't contact us via phone, please email your questions to me at Huntley, HUNTLEYP, at MMHP.org, and I'll try to get answers for you. No more questions from out there?
They have not.
Nope, Dr. Robinson just put.
Oh, Virginia Lawrence wants you to repeat your email address.
My email address is huntleyp, HUNTLEYP, at M as in Mary, E as in Edward, M as in Mary, H as in Hector, P as in partner.org.
She also is the person who sent out the presentation information, so you have it if you want to respond to that email.
So, okay, so Dr. Robinson also saying, some of us met with another reviewer this morning. His take was that the number of diagnoses was not synonymous with increased medical complexity. He was apparently bashing this on his experience defending providers charged with overcoding. How do we reconcile your perspective with his?
Oh, lovely. Conflict management, isn't that what you people do for a living? Yeah, I'm not valid at all. Okay, so here's my take on it. I try to be very conservative, and the number of diagnoses that you're managing, if they are truly affecting the care of the patient, I believe are part and parcel and do add to the acuity of your medical decision making. The only thing that I can think that this person meant by that is if, for example, you have a patient that you're seeing who has a plethora of medical conditions that you are not treating, that are not affecting the treatment of that patient, then you're absolutely right. Just throwing them on there is not going to add to the complexity of your medical decision making. I think that goes to the question we had here as well. If you just plug in there that this patient has diabetes, that does not mean that that you have to kind of indicate that there should be a clear indication that type 2 diabetes is affected by the atenolol that's being provided to the patient with ADHD, because that is going to affect their sugars. It's going to affect their weights. It's going to do all of those things. So there is a cause and effect relationship. I would say that if a patient is on Ritalin and has hypertension, that's another one that you would want to list, because guess what? That increases, the patient's hypertension. But if you're going to put down the fact that this patient has gout and the medications that you're giving them are, not affecting this patient's gout, then you're right. That's just falderall. That does not affect the additional complexity for that patient. But if it is truly affecting the co-management or the management of this patient because of the medications you're prescribing, it does affect your overall medical decision making.
Just to clarify, I said bashing and it was supposed to be basing. Apparently my accent is going through.
I knew what you meant.
But there are a couple of other questions. Dr. Robinson also wants to know what happens to 90847 and 90846.
These codes still exist. They are not psychotherapy codes. They're those are the group therapy codes, I believe. Family and group.
Family with and without patient presence.
Yeah,
code.
nothing is changing on those.
Nothing has changed.
Okay, and then Sandra wants to know, are these templates going to be amended to the EMR, Meditech, and Epic?
And Desjardins stepping out of this one. We're trying.
This is Andrea Maher from IT. Depending upon your system and your system's ability to use interactive templates, yes. Meditech, for example, will have a common template that will be decided upon, one for outpatient, one for inpatient. It's interactive. it will follow the same format but we'll still have the, what am I trying to say, the limitations that Meditech has now. So it's not going to suddenly act as a new system, and it's not going to be able to count things for you and things like that. CCC's EMR template is very basic. It's just like pulling in words from a document, so there's no interactivity in that. Epic is down the road, and I can't really speak to that right now.
All I can say about Epic is that we are making the template that psychiatry has approved for
Mike has
Epic.
actually commented on that.
Oh, great. Can't see.
We will not be building templates in Epic. Perhaps MMC staff will, and we are willing to share with them.
Yeah.
Okay.
Okay.
That answers that. And for the other systems, they're not doing templating in the systems anyway. CSI, Midcoast, it's not. It's
Right.
a different.
But we are using templates as a dictation tool
Yes. So that
for
will-
those providers who are not using an EMR today.
Well, thank you for your time and attention.
I'd just like to remind everyone that we have recorded this. Hopefully, we'll record 2 sessions. And so you can go back if you wish to hear parts of this again.
And count my ums.
And so that communication will be sent to you as soon as we have information on how to access the recorded system. Also, please remember to send me your evaluations, because that will be key to getting your CME certificate for this session. And also a reminder that the handouts that were sent to you yesterday afternoon, late yesterday afternoon, are the most updated at this point. So if you had them from last week's session or Monday's session, please do not use those. Use the ones that were sent out for today. And with that, I believe that we are done. I thank everyone for your participation, and please forward any questions to my email, and I will try to get answers to those questions. Thank you.
Thank you.
Thank you. Thanks for your time, folks. I really appreciate it.
Thank you.